Welcome to HEALTHlines. I'm Marilyn Lagniton, your host. Neurosurgery, commonly known as brain surgery, is the surgical treatment of disorders affecting the brain, the spinal cord, and peripheral nervous system. I have just the right person to break down those big words. Dr. Mike Gimenez is a neurosurgeon with subspecialty in critical care and spine surgery. He's the chairman of the Brain and Spine Institute at Cardinal Santos Medical Center. I am very interested to know about the Institute, which actually is known to be a prime mover in the development of neurosurgical specialties in the Philippines. Dr. Mike, that's Dr. Mike Gimenez with a G. Thank you for being with us today. I am delighted to have the conversation with you. So let's start straight away. What is the Brain and Spine Institute? Tell us about that.
Okay. Thank you, Marilyn. Thanks for having me here. Well, just to give our audience a good idea, the Brain and Spine Institute is one of the institutes under the medical division of Cardinal Santos Medical Center, and it's basically a multidisciplinary unit. I think a key word there is multidisciplinary because it is made up of doctors of varying specialties which deal with diseases in the neurosciences. So our institute, to break it down, is composed of centers which deal with diseases, varying diseases and subspecialties in neurosurgery and neurology. Now, the Brain and Spine Institute was conceptualized about 2 decades ago, primarily as a neurosurgical unit, but it has developed into a multidisciplinary and comprehensive unit for treating diseases in neurosurgery and neurology.
You've said the word multi-specialty several times, and I would imagine it's different specialties under one unit. What kinds of specialties are you talking about? And I said earlier that neurosurgery most commonly is thought of as brain surgery alone, but that's not so the way you said it. You said multi-specialty. What kinds of conditions do people who come to you have?
Well, primarily a neurosurgeon deals with surgical diseases for the brain, and the spine, and as you mentioned, the peripheral nervous system. And just to give you an example of the diseases, we deal with adult and pediatric brain and spine tumors, and we have centers within the institute which deal with this specifically. We have a center which deals with the different types of strokes. And this is, of course, in collaboration with our colleagues in neurology. We have a specialty center, we call it the Spine Center, composed of both orthopedic and neurosurgeon faculty, which deal with the complex problems related to spine. They can be degenerative, they can be from tumors, they can be from infections and all other pathologies related to spine. We also deal with movement disorders. Those, when you say movement disorders, typically they are called Parkinson's, Parkinson's disease or even dystonia. And what we manage in our movement disorder surgery center would be those movement disorders which are refractory to medical care, those which do not respond to medical care. And we have a special kind of operative procedure that we offer for this very debilitated patients.
Okay, these are lifetime diseases. Am I correct?
Correct.
Okay, and when you say you have operative services that manage the disease, does that mean the person, because it's lifetime, but does that mean the person gets well at some point? Or is that just improving the quality of life?
It can vary. For some diseases, they can be given a cure.
Okay.
Some diseases can be controlled long-term. Benign diseases can be controlled long-term, but if you can actually give them a cure by taking the whole tumor out, for example, or you're able to address a ruptured aneurysm permanently, then they are cured. However, some of the treatment that we convey can only afford palliation, prolongation of life, improve of functionability, and of course, which translates to quality of life. So we deal with cancers, we deal with benign disorders, strokes, movement disorders, spine problems. And more recently, we've actually delved on other specialties or problems like memory problems, insomnia, And more recently, we're trying to set up an epilepsy surgery center for patients who do not respond to, with seizure disorders, who do not respond to medical treatment.
If I'm like every common person out there on the street, all of the things that you've talked about are either very scary or I would feel very fearful. How do I know that I need to see somebody like you? Or how do I know that I need to go to your specialty center that need your kind of care? How do I know now that I need to go to you?
That's a broad question.
Yes.
That somehow needs to be fine-tuned in terms of the appropriateness of seeing the right person or the right doctor. Well, you have cardinal manifestations or symptomatology that are quite common even to the lay people. You can have patients who can present with headaches, with nausea and vomiting. We call it pressure signs related to brain problems. You can have blurring of vision. You can have weakness or numbness of one side of the body. You can have patients who present with seizures or epileptic attacks and movement disorders. I mean, incoordination, imbalance, all of those. But you have to understand that most of this can actually be from common problems, hypertension, other medically related problems. But there are specific characteristics of these cardinal manifestations that would eventually make you realize that you need a neurologist, you need a neurosurgeon, or somebody allied to our specialties. I'll give you an example. When you talk about headaches, most headaches will not be caused by a brain tumor. But if you have a headache that is progressive in nature, that is accompanied by what we call neurologic symptoms, like it's accompanied by blurring of vision, doubling of vision, or a neurologic deficit like weakness of one side of the body, then that may point to a neurologic problem than something that is not. So if you put this all together, then it may actually give you an idea that they have to somehow be turfed towards us. In general, progressive nature of disease, whether it be headaches, back pain, blurring of vision, imbalance, seizures, especially late onset seizures. So that would really point you towards needing neurological consultation or care.
Very interesting. I want to talk to you more about that at the other side of this break. Okay, so stand by. We'll be back. Health news that matter. Only on HEALTHlines. On CSNN, your Cardinal Santos News Network. We are back. This is HEALTHlines. I'm 𝗛𝗟𝗏𝗛𝙣, and I am with Dr. Mike Gimenez. Again, that's Gimenez with a G. So we were talking about the signs for patients who might come and see you. And some with urgency, some with just beginnings that can be managed well. Give me an example of how you have made lives better or extended lives, especially in the last maybe 3-5 years. I know that you're very progressive in the unit and you talked about adding many more specialties. What have you done in terms of making, you're the prime mover. You're the prime mover unit in this country for neurosciences breakthroughs. Give me an example of that. I'm very, very interested to listen.
It's really how we have collaborated for more than a decade with the other allied specialties. And this is why we call it a multidisciplinary unit. Okay. So the good outcome will not come from just neurosurgical care. I cannot do that alone. As a neurosurgeon, I have my own biases towards managing patients. You can't take that away from me because that's what I learned from my education. However, the multidisciplinary unit, is what gives you the checks and balance. I'll give you an example. I'll delve on brain and spine tumors.
Okay.
Now, we have 9 centers in the Institute, and one of those centers is called the Brain and Spine Tumor Center.
Okay.
Now, this center is not composed only of neurosurgeons, but we have adult and pediatric neurologists on board.
Mm-hmm.
We have oncologists in the medical field for adults and pediatric patients. We have radiation oncologists. We have neuropathologists, neuro-oncologists. So all of these doctors actually, what's very unique about us is that we meet every week, and all cases for the past week with brain and spine tumors are actually presented during that Tuesday conference. And so, for example, if I have a patient who I saw yesterday, I'll tell them, yours is a complex case. Let me present this to the group so we can have a consensus of opinion. So you make use of collaboration to be able to educate the patient in terms of the specific options of treatment. And the options of treatment will not just be neurosurgical. It may not even need neurosurgery. You may just need radiation therapy or chemotherapy or a combination of all 3. Now, if I have an MRI there that's done outside, I have the best neuroradiologist in Manila who will look at that MRI on that day of the conference and give me his inputs. So that will give me a fresh perspective on what I'm dealing with. Okay? If I have taken out a tumor and I present it the following week for a follow-up, my neuropathologist will now tell me it's this kind of a tumor. It's a grade 2 glioma, for example. So that's a kind of tumor with a different grading depending on its aggressiveness. And then I will now ask my medical and radiation oncologist, what's next? I took out the whole tumor, but this can recur. So what's next? So all of those things are put together and basically offered to the patient and the family.
Are there times when some of you disagree?
There is always disagreement.
Okay.
And that's why you need a meeting of minds. Okay, so there's no star there in that meeting. The star is the patient. So we put the patient's interest above everybody else. Eventually, if there are options, you cannot agree on one single treatment option, you then present that to the family. And you present that in a way that you actually educate them, because they will never be comfortable with any treatment option for the brain or the spine unless you educate them.
And especially for the brain, the word tumor in and of itself is something like a death sentence, or it used to be anyway. What is the survival rate of people? And again, it probably depends on how often or how soon it was seen, right? But what is the survival rate in this country? Is it better today than it was, say, 5-10 years ago? How many people, like after 3-5 years, survive, etc.? And is mortality also down from years past?
Well, it's very difficult to give you a specific number because there are 120 kinds of brain tumors. Right. So each specific brain tumor will have what you call a prognosis and an expected long-term outcome. Now, how much have we changed the past decade or so? I'll give you an example. We have another center in the Brain and Spine Institute. It's the Philippine Gamma Knife Center.
Okay.
The Philippine Gamma Knife Center is a stereotactic radiosurgery unit, meaning you use it to treat brain lesions alone, mostly brain tumors, and you do it by giving a very high dose of radiation to that tumor without hitting the rest of the brain. So it's a focal treatment that is non-invasive. You don't need to make any incisions. It's done as an outpatient procedure. It's revolutionary in terms of how it has actually helped people all over the world for several decades. And we've had it for 2 decades only in Cardinal Santos.
Wow.
Cardinal Santos is the only place in the country which houses a Gamma Knife Center. So we have that distinction. Now, how has it helped our patients? If I have a patient with the lung cancer and the cancer has spread to the brain, that is a death sentence. I'm just using your term.
Right.
All right? Nowadays, if we can treat that patient with the gamma knife, very high likelihood that we can control the brain tumors, the growth of the brain tumors. And then from there, we move on to treat the rest of the cancer with chemotherapy, immunotherapy, depending on what our medical oncologists would decide on. So that has been revolutionary, that has prolonged life for specific cancers like breast cancers, which respond very well to systemic treatment. But whenever they go to the brain, it's a death sentence. And we have extended the lives of these patients, and not only their lives, but quality of life, which is, of course, as important as life expectancy.
When you see patients many times with their families, how educated are they today? How educated is the public today? Again, I need to say compared to years ago. And I know that there's a lot of material there. Dr. Google, that's looked up by a lot of people. And, I would like everybody to know there's a doctor here, and there are many doctors at Cardinal Santos that you can go to instead of Dr. Google. But are people generally more educated about healthcare, especially their own health?
In general, people from all levels of society, all walks of life, are more intelligent nowadays. Primarily because of access to internet.
That's great. Yeah,
I mean, you can have a high school graduate daughter who reads everything in Google, and so when they come to you, they're very well versed about treatment options. Most of the time they're a little off, and that's your role to actually, in a very objective manner, to try to will them back in and make them understand it more. You have those very intelligent patients and relatives who've had opinions elsewhere. It's so easy getting an opinion abroad. So we're just so used to that. The important thing is to be receptive, and then allow them to ask their questions, and then in a very methodical way, educate them in the process.
We're running into another break, but I would like to know, give me an example of how you and a patient have come together. I'm interested to see how a fearful or a patient who's so afraid comes to you, and many times we're even afraid to go have some treatment done because we're better off, we're alive now, we don't know how we will be after treatment, especially for a major surgery, whether it's non-invasive or invasive. I mean, that's something. But we'll talk about that when we come back from this break. This is HEALTHlines. I'm Marilyn Lagniton, and I am with Dr. Mike Gimenez. I really want to say it again. That's Gimenez with a G. So I was asking about an example of, how you put a patient to ease. It's a major time in the life of not only the patient, but the family, especially if the patient has kids. Give me an example of how that goes in your clinic, for instance.
I think this is really where the humanity of our profession comes in. Specifically, you need a lot of empathy to be able to make a patient who's very scared, a family who has a lot of apprehensions and even doubts about your capabilities, about the chances of their relative, to be able to convince them that you can make a difference. First of all, you have to be very honest with them. I think they can see that if you're sincere.
Is that a problem? Sometimes family members says, don't tell them. Or that happens, right? So you tell the patient without the family member? How does that go?
Well, you do get that a lot.
Right.
Children telling you, huwag niyo hong sabihin kay nanay. Takot si nanay, nervyosa si nanay. I just had that yesterday.
Really?
So we get that routinely. First, the most important thing is to make the family realize that whatever they do, as long as the patient is awake and has intact faculties, they will know that something's wrong. They will know that you're actually hiding something from them. Your role is to be truthful, but to be softer with the patient rather than with the relatives. I would say that because, you have to deliver it in a way that they can actually accept the details of their condition in a way that does not really break them down or make them even worse. Easier said than done. But again, I guess it's an art. And again, you use empathy. You just have to tell them that we're doing this for a specific reason. You have to set the goals, the objectives of why you have to do something. And if you feel that it's always a risk-benefit ratio. If you feel that the benefits of any procedure outweigh the risks, you now emphasize that to the patient and to the family. And most of the time, you actually succeed in developing that rapport with the patient and, of course, the family.
But do you talk to the patient about the risks as well?
You do have to do, because they have to sign, either the patient or the relatives, they will have to sign what we call an informed consent. It's not easy to deliver that. But again, you have to put it in numbers. You have to put it in a very objective manner, and then give them the complications vis-a-vis the problems if you don't give treatment. Right. So if you don't give treatment, it's going to end up like this. If we give treatment, there's a good likelihood that we can get to this. And this is our goal.
And are patients today more compliant with directives of post-visit, post-admitted care? Like, okay, when you go home, there's no doctor that'll tell you, or there's no nurse that'll come take your meds to you. Are patients more compliant? That was an issue.
The answer to that would be two-pronged. Number one, yes, they are more compliant nowadays, but it's also with the manner that you actually advise them. If they have problems at home, they need to have a number to call or to message. If they're 2 days post-op and they see something wrong, fever develops, they need to know how to address that with medications or by informing us. So we need to have that open line of communication with them. And I think that matters in terms of patient satisfaction. And, it really depends on how the patients are before their surgeries. We do end up with complications. But for the most part, I think with what we've been doing, with our collaboration with the other doctors, we've been doing a pretty good job, I would.
We've come right to the end of the show. That ran really quickly. When you're having a good time, I guess time flies. So it was a very good conversation. We got to take one last break. We'll be right back. We are back for one last time. Dr. Mike, it was such a delight to have you. Tell people out there how to see you, when to see you.
Okay. Well, again, thank you, Marilyn, for this opportunity. Well, again, the Cardinal Santos Medical Center Brain and Spine Institute is here for the Filipino people. What we want to give our kababayans is accessible expert care in the neurosciences. As a final message, what we can give our patients is really merging of collaboration amongst our doctors, using the advanced technology that is at our disposal, and lastly, the proficiency and the expertise of each trained medical doctor in our multidisciplinary group to give you personalized and empathic care. So we continue to evolve, we continue to try to improve, but we're here for you. Thanks very much.
Thank you very much, Dr. Mike Gimenez. Again, that's Gimenez with a G. And to all of you who stayed with us, Thank you. We hope we have learned so much from this very short conversation with Dr. Mike Gimenez. He is the chair of the Brain and Spine Institute of Cardinal Santos Medical Center. We hope that this episode was able to provide for us some enlightening takeaways that we can find useful not only for ourselves, but for our families and our loved ones. This has been HEALTHlines on CSNN, your Cardinal Santos News Network. Join us again for the next conversation as we break yet another of tomorrow's health headlines today, only on HEALTHlines.